You go first.
Okay. My name is Siobhan Kiernan. I'm a social worker at University Hospital. I have been a social worker since 1998, and I've worked in both the like a psychiatric unit itself, but I've also been an outpatient therapist at a mental health clinic. I've always worked in the nonprofit field.
My name is Luis Santos, and I'm a clinical social worker with supervisor status. I've been in the field of mental health for more than 20 years. Currently work at University Health Hospital, and I started off in mental health doing home visits for the Center for Healthcare Services, the local mental health authority in Bexar County. I did that for 5 years with folks with severe mental illness. So I had the privilege of getting to know folks when they were not coming to the hospital or the clinic, but rather at home with their families. I got to meet their families, and I got to meet the different dynamics that folks go through, and how difficult sometimes it can be. Sometimes the homes were not homes, sometimes the homes were shelters or the streets. But anyway, I'm very happy to be here. Thank you very much for inviting me.
Great.
I think that we both feel the very same way, is that it is the fundamental first piece of treatment. When you think about someone who has an illness, a psychiatric illness, and that is all Luis and I have ever worked with, is severe mental illness. Um, we typically see folks who have been admitted to a hospital, and while they're there, they get the medical and psychiatric attention that they need. One of the things people don't realize is a lot of folks that come into the hospital who are homeless, the healing is not just the medical and the psychiatric piece. Part of the healing is sleeping, resting,
Mm-hmm.
and decent food.
Mm-hmm.
And so the person gets treatment there, but they also are safe there, and they're getting their very, very fundamental needs met. So from a jumping off point, housing is essential to treatment. Without it, people are not able to pursue a successful life outside the hospital.
Uh, that's absolutely right. I think with almost 10 years of working inpatient at the hospital, not just in psychiatry, but also in the emergency room and general medicine, I'm often asked, why am I being discharged? I'm not ready to go yet. In the United States, a person doesn't get admitted to the hospital unless their life is at stake. Um, the healing doesn't happen so much in the hospital. So I say something very controversial. A hospital doesn't heal you, a hospital saves your life. The healing comes in between. If there isn't any predictability, if there's no structure in those in between times, healing is very difficult. I also have come to appreciate the severe mental illnesses aspect of thought disorganization. And that's something we don't really ever talk about, because thought disorganization happens to be a system of symptoms in multiple severe mental illnesses. And it's thought disorganization that makes a person not be able to think clearly, gets confused easily, can't follow through linearly. Thought disorganization, some would say, is not imminently dangerous. So we hardly ever see it coming up in the judicial system, in law enforcement or in hospitals. It's not immediately as dangerous as hearing things that tell you to hurt yourself or hurt somebody else. Thought disorganization, however, can be just as dangerous in the long run. And this is why we need housing, because it is an external imposition of a structure. We can help folks develop some sort of organization of thought in the midst of poverty, the weather, lack of resources, lack of medication, lack of natural supports, community, uh, a certain disconnectedness is what the ultimate results of thought disorganization can lead to, and that housing can fight that.
I think that the thing that most people don't think of is when someone discharges from the hospital and they're homeless, they're not going to be concerned about when their doctor's appointment is, how they're going to get their medication. Um, those are issues that are a luxury for them to think about, because what they're thinking about is, where am I going to sleep tonight? How am I going to be safe tonight?
Mhm.
What am I going to eat today?
When we're talking about needs, I think we all, whether a person has a severe mental illness or not, being able to connect to humans, being able to connect to natural supports. By natural supports, I mean family, friends, folks we can develop a certain consistency with. That is often found in the streets, actually. There is a certain network of connectedness, but it cannot parallel recovery as well as housing. I think that housing is what allows for more connectedness to happen in an organic and natural way. I had the privilege of working for the VA in Galveston for a year, and we would help folks come off of the street who were so compromised with substance use and severe mental illness. And it was a very interesting phenomenon to be able to get them housing, and within a 2 week period have them leave the dangers of the streets and into a secure apartment unit.
Mm-hmm.
But it was in a random selection of available apartment units. It wasn't within an immediate community. So to establish a place where there is connectedness from the very beginning is also another degree of supporting the recovery process, making sure one is buttressed on multiple sides in terms of reaching their recovery goals. And the natural organic community development is incredibly important.
Absolutely. One of the things when I took my position, where we work, we're very, very lucky. We have access to several different housing, free housing that we can send our patients to. And when I took my position, I started accessing those. I'm not sure if anyone had in my position beforehand. I really think finding secure housing is the biggest impact we have for treatment, for successful aftercare treatment. Because once someone is safe, like Louise has said, they can then begin to fulfill other emotional needs that a person fundamentally has. Plus, they can then at that point worry about things like taking care of their health, developing interest in hobbies, becoming a well rounded person. Without housing, none of that's going to happen because it can't.
Well, our roles are. That's a good question. The obvious answer is it's way too many. Uh, the the actual numbers we could see, I think collectively among our team. Well, Siobhan covers the entire hospital, so she can encounter up to 700 patients um, on any given day, actually. And if
Wow.
one were to see the severe mental illness rate of 10%, we're talking about 70 folks a single day that we have to keep keep on our radars to be available to serve them. If we were to look at how many of those 70 are homeless or experiencing homelessness, man, it's at least a fourth, I would imagine. That just off anecdotally, I can imagine it's about a fourth out of every census. We have to consider housing options.
That's significant.
I would say on a weekly basis, on average, I work on placement between 4 to 7 patients a week. I've had days where I discharge. I remember one day in particular I had off. Luis was not happy when I showed up at work.
Yeah.
I had 7 discharges, and out of those 7, 5 people had I not pursued trying to get placement for them, they would have discharged to the street. It is a massive problem.
Yeah.
And if COVID has taught us anything, it is the most nightmarish experience for any social worker or physician to have to discharge a person to nowhere. When COVID hit, the emergency shelters, transitional housing shelters, were not able to take in anybody. And it was so scary for us to tell somebody you're homeless and you're gonna go back to the streets. Luckily the community came together and came up with some emergency protocols, and the city government was really great at that. But so much of that could have been avoided with some substantial housing from the very beginning. It highlights how vulnerable we are when we don't have housing.
Anytime I think we've discharged someone from the hospital, or we have found housing for a patient who or a client who was homeless, it changes the trajectory of their life, and if they're a single family, the trajectory of their entire family's life. Right now we've been concentrating, really, we're just speaking about our personal patients, but sometimes I've had patients that are women who are being abused, and they've been in a shelter. And it's, you get that mom and her kids into a stable housing situation, they flourish, both the mom and the kids.
I think of a number of clients, patients who had a transformative moment at the hospital, an awareness that they are worthy of love and worthy of giving love. I'm thinking of the folks who had been taken advantage of because of their mental illness and had developed a certain protection by keeping people away. I have a number of patients in mind, recently even, who had ironically built walls around themselves in an effort to maintain safety, emotional safety, and a sense of self-worth. When those walls collapsed, a crisis moment hit. They were admitted, luckily, to our unit, and we were able to have talks about the dignity involved in self-protection. And it was perhaps the only time that the person felt protected was when they applied security and safety for themselves. To then say, and luckily we didn't have to worry about this because our leadership has made arrangements with certain transitional housing options, but they're temporary, transitional. We were able to maintain that same trajectory once our client had reset the coordinates on how worthy are they of love and how worthy of them receiving it and giving it. Was there any hope left, um, were they were their efforts worthwhile? To send somebody back out to the streets is so anticlimactic. It's so difficult to maintain that momentum, to maintain that goal of holding on to one's self-worth, ego construction. Um, and if we could establish a place where they could have real walls, where they could have a sense of consistent security in a community, then we wouldn't have to build emotional walls around ourselves, and be able to retain that sense of self-worth, worthy of receiving and giving love. It's very, very um, complex of an idea to go from something very concrete to very abstract, but that's the reality of the recovery process.
And just to take that a step further, we see a lot of SMI, significant mental illness, with co-occurring addiction, specifically folks that are not treated with psychotropic medications. So for folks who are diagnosed with schizophrenia, schizoaffective disorder, bipolar, whatever type of bipolar, without that medication, you start to look at addictions. I think the rate of co-occurring with an SMI is about 80%. And for me personally, those are the patients I see a profound change in.
Mm-hmm.
If they have that moment in the hospital that crystallizes to them that they cannot live like this, that there is treatment and recovery actually can happen, it can consistently work for them. I think those have been the patients I've worked with who have been incredibly successful once they have secure, stable, sober housing.
And the other issue is that a lot of the folks we encounter wouldn't have to be at the hospital or even reach a crisis moment if they had been residing in a place that was predictable and safe and constant. So it's a society's investment.
Mm-hmm.
It's preventative medicine to have housing. So it's on multiple levels. It's a necessity.
And fiscally, it makes a lot more sense because you are then avoiding people coming into the hospital under a crisis situation that can cause, if the person's not insured, and that happens frequently with folks with mental illness because of thought disorganization, they're not able to make those steps to worry about the Affordable Care Act or CareLink or something along those lines. So that becomes a taxpayer expense where we're paying for frequent psychiatric hospitalizations. And instead of taxpayers throwing money towards a crisis, wouldn't these people be better served if they had secure housing where they had people that they had organic relationships with, where we had staff who were professionals that could de-escalate what could become a crisis situation that could become acute where they would need a hospitalization? It's not just the humane thing to do, it's the fiscally smart thing to do.
There have been times where folks with severe mental illness get arrested and taken to jail for nonviolent crimes simply because of their exposure to the community and being in the wrong place at the wrong time, not knowing, not in any way even attempting to trespass. They're simply there. Somebody doesn't agree with it. Law enforcement doesn't know what to do or lacks options at the time, lacks resources. And they wind up going to jail. And folks like Shaban will find out and have a way of working with other team members of helping the patient the inmate get into recovery and becoming a patient instead, and then helping them get into some sort of some transitional program. I think that's tremendous to be able to help somebody who really needed recovery treatment rather than punishment. And that is one very obvious extra problem that somebody with homelessness faces. Uh, Charges such as trespassing or failure to identify. Uh, and yeah, that it could be very heartbreaking to see some of those situations. And it's not, I'm not blaming law enforcement. Sometimes it's probably law enforcement's efforts at keeping everyone safe at that time.
For me, I think the one thing, the one thread that I see with individuals that come in that have been homeless is trauma. These are folks that end up having pretty profound trauma. And that trauma can be something where they were psychotic and they were trespassing and someone had them arrested. And they have no idea that they even did anything wrong. But it can also be a woman who was sexually assaulted on the street because she had nowhere to go, and she comes into the hospital because she is acutely suicidal. Well, she wouldn't have been acutely suicidal had it not been for the trauma. So I think for me personally, the thing that I see is a trauma background. And it's usually not a single trauma. This is a person who's had multiple episodes of traumatic situations.
Yeah.
There's a saying that marijuana, cannabis, is a gateway drug. I don't believe that. I think trauma is a gateway. I think that's the gateway drug.
Yeah.
And you take someone with a mental illness who may not have the emotional support or the medical support with proper psychotropic medication, and they will turn to drugs or alcohol. So taking a woman, for example, who's been sexually assaulted, who then has to go out on the street, that woman has a high likelihood of using stimulants because that will keep her up for days, and that will protect her from falling asleep and being re-victimized.
There are a number of models from Canada all the way down the west coast of the housing first. Some do it without question. Some have a blended housing first. Our federal government, through programs like HUD-VASH at the VA, believe in the housing first model, which means that we have somebody who is in the process of changing their lifestyle of addiction, haven't fully recovered, they're still using, or they might be pre-contemplative, but they're homeless. Housing first will say, give them a house. They're not going to be able to recover without the house. Give them housing. Oh, but they're going to bring drugs into the house. Give them a house. But they're going to bring other people in. Give them a house. And so there's this idea of housing first being the foundation and the recovery scaffolds on that foundation. So we have lots of success evident through the HUD-VASH program throughout the entire country, where veterans, that's HUD, Housing and Urban Development, VASH, Veterans Affairs, Shelter and Housing. Anyway, HUD-VASH is a marvelous program through the VA and HUD to help veterans with chronic homelessness get into housing. Then recovery becomes so much more possible. Every single one of my veterans on my 40 veteran caseload had been chronically homeless, had been very unsafe living behind dumpsters or under bridges, and were exposed to drugs. And there's some drugs that are very stimulating and keep you vigilant, which is probably a helpful effect when one is living out in the streets and exposed to all sorts of dangers. So to pass judgment on somebody who has an addiction to stimulants or an
Mm-hmm.
addiction to depressants is it's a very tricky thing, and I don't encourage judgment on anybody who's doing drugs. It's particularly when homelessness is around. It's a complex relationship with the drug that is in some paradoxical way, to a degree, protective. Obviously, it's dangerous and bad, but when you get housing, the hypervigilance is no longer that necessary, and so there are other elements to consider in that relationship with substances at that point. And you know there's less rationalization for it. That there's less of a need for it. Um, and so yet another reason why housing is such an effective way of recovery. When I was able to find housing for a veteran or for a client in a community that was pretty isolated from the regular systems of care that the veteran was engaged in. So we'd find an apartment complex, and the veteran knew no one there, absolutely no one there. It was not unusual that in a number of weeks, the environment inside that apartment unit mimicked the environment that the veteran had been used to for 2 or 3 years while living out on the streets. I'm talking about it being cluttered, cats everywhere, uh, just a mess. But it was something familiar. It was something secure. At one point, we would have to call Adult Protective Services to come and engage them, and hey, you got to lead a healthier lifestyle. What we did was we brought them into groups. We'd go pick them up and bring them into weekly support groups to maintain that at least a mental community. However, when we were able to place somebody in a unit that had other veterans or people of the same history and same experience and same perspectives on life, there was much more organization. There was much more volition. In other words, wanting to get more things done. There was less withdrawal from society. There was more involvement. The appointments were kept more often. So it was the element of connectedness again in community was so important in successful housing and successful recovery.
I actually, now that I think about it, I did at one point work in uh, in a transitional uh, facility for women and children, and I found the same thing. There was only one woman that relapsed, and um, her outcome was unfortunately not good. But every other woman who was there was successful.
With practically every human process, we want to fundamentalize things and think that goal achievement is linear. We start here, we do some investment, and it's going to go proportional, and we're going to reach our goal. Um, that hardly ever happens in human experiences. What we need are what we need is just an acceptance, a surrender to the fact that we have to have iterative processes. So we may get to our goal, we will, but it won't be linear. It'll be like revisiting something that we needed a gap that we didn't fill in the process, and then maybe make a little bit of progress this way, and going back and reevaluating and reinforcing. New challenges come up, internal obstacles, ideas that were not worthy of happiness, and uh, all of a sudden changes, big mega changes, a death in the family. But you keep providing the sufficient power. It's all really an empowerment process, is what we're talking about. You will eventually get to it, but being comfortable and surrendering to the fact that things are iterative when it comes. So we need to have established a structure, such as a housing complex, that would allow for revisiting how recovery is progressing. So being able to establish a housing uh, complex that would allow for um, evaluation of the recovery process on a regular basis, having somebody present in the apartment complex who's going to be a reality base or the baseline monitor, I think is incredibly helpful. So all of that was very philosophical, and I'm remembering my mentor, Don Arispe, who taught me about the iterative process. But the thing is that if we are going to approach housing with the idea that we're going to go solve a problem and then ignore it, it's perpetuating the exact same idea. It's this idea that we can throw a solution at a problem and it gets fixed and we can completely ignore it. Never. Every human system is going to continue developing in different directions, and we have to be able to go back and visit. It's not just teaching the man how to fish. So it's also going back next week and say, hey, have you tried this different lure? And how's your fishing rod? Is it still working? So it's it's that degree of revisiting that is important. I think housing, if we look at it in the history of humanity, housing has been much more than just a concrete shelter. It's been the source of understanding oneself, being able to reconnect with oneself. It's usually where one reconnects with God and the transcendental. It's so much more than just um, having a safe place to stay. It's so much more, and I don't mean to sound cynical, but it's so much more than just removing somebody we don't want to see homeless on the street and putting them in a place where we won't have to see them. It's about the dignity of the community and dignity of the person on multiple levels. That's what housing is. We simplify it by giving it the word housing, but it is what every faith tradition has always worked for, which is giving a dignity and purpose to our creation, to why we were created. Housing is very vital in that.
We're talking about housing. Our patients are talking about their homes. This is about someone's home, and it's fundamental.
Thank you both very much.
Thank you.
Thank you.